Welcome to the deep dive. Today we're cracking open a truly fascinating chapter from Atkinson and Hilgard's Introduction to Psychology 15th edition to explore a monumental question. How has our understanding and treatment of mental health radically shifted throughout history, and what incredible breakthroughs are happening right now? We're taking you on a journey through centuries of thought about the human mind, from ancient beliefs to the most innovative treatments being explored today. Get ready for some surprising facts and profound insights into how we care for mental health.
And that's precisely our mission with this deep dive. We're going to pull out those essential aha moments from the source material, helping you grasp not just what happened, but why these shifts in mental health care were so transformative. By the end, you'll walk away not just informed, but with a truly nuanced perspective.
Okay, let's unpack this, starting right at the dawn of human history. Imagine the Stone Age. When people saw unusual or disturbing behavior, the prevailing belief was that individuals were possessed by evil spirits. And the treatments for these demons were, frankly, horrifying. Prayer, incantation, magic. But if those failed, they resorted to truly brutal measures like flogging, starving, burning, and even profuse bleeding, all aimed at making the body an unbearable home for the invading spirit.
It's pretty grim. And what's truly fascinating is the stark contrast with the ancient Chinese view around the same time. They didn't see it as possession, but rather a disruption of balance. They believed the human body contained positive and negative forces, and an imbalance could lead to insanity. They also had this intriguing concept of vital air influencing emotions on specific organs like sorrow on the lungs, anger on the liver, worry on the spleen.
That's so different, a holistic internal view focused on harmony rather than, casting out demons.
Exactly.
So after centuries of blaming evil spirits, imagine the revolutionary idea that our minds might actually be connected to our bodies. That's where Hippocrates, the Greek physician, steps in. He's credited with bringing a medical perspective, suggesting that unusual behaviors resulted from an imbalance in bodily fluids. But more importantly, he and other Greek and Roman physicians advocated for incredibly humane care.
Yeah, things like pleasant surroundings, exercise, proper diet, massage, and soothing baths. While they didn't have dedicated institutions, individuals were often treated with remarkable kindness in temples dedicated to healing. It was a big step forward.
Huge step.
Unfortunately, this progressive view didn't last. The Middle Ages saw a severe regression. Primitive superstitions revived the belief in demon possession, and mentally ill individuals were tragically linked to Satan.
Oh, man.
Yeah, this led to incredibly cruel treatments, beating, starving, and torturing, all believed to punish the devil within. This dark period culminated in the horrifying witchcraft trials in the 15th, 16th, and 17th centuries, where thousands, many likely mentally ill, were sentenced to death.
It's a truly chilling chapter. Moving forward, by the late Middle Ages, cities started creating asylums. But these were essentially prisons. Inmates were chained in dark, filthy cells, treated more like animals than human beings. Just awful.
Absolutely awful. It really wasn't until 1792 in Paris that Philippe Pinel made a groundbreaking change. As an experiment, he dramatically removed the chains restraining inmates at an asylum.
People must have thought he was crazy.
Oh, they did. Skeptics thought it was madness. But the experiment was a success. Patients, once freed, moved to clean, sunny rooms and treated kindly, showed significant improvement. Many, considered hopelessly insane for years, actually improved enough to leave. This wasn't just humane, it demonstrated the profound impact of compassion on mental well-being.
Pinel's actions were truly revolutionary, sparking a new paradigm.
Definitely. Then, fast forward to the early 20th century, and medicine made a pivotal breakthrough in 1905. The discovery that general paresis, a severe mental disorder causing both mental and physical decline, was actually caused by a syphilis infection. Yeah, and the subsequent success of penicillin in treating syphilis dramatically reduced cases of general paresis. This wasn't just a medical achievement. It was a profound philosophical earthquake. It proved for the first time that what we considered madness could be a treatable physical disease. You can imagine the ripple effect that had on public perception and research, firmly encouraging the biological view of mental illness.
Indeed. And it's from this backdrop that modern psychiatric hospitals evolved. The best ones offer comfortable therapeutic environments with individual and group therapy, recreation, occupational therapy, education. The works.
Right. But the source also points out that the worst are primarily custodial, with patients enduring boring existences in rundown, overcrowded wards, receiving little beyond medication. And most, sadly, fall somewhere in between those two extremes.
Which brings us to a significant shift that began in the early 1960s, the move from hospital-based treatment to community-based care.
Exactly. This was driven by the growing recognition that hospitalization, no matter how good the facilities, had inherent disadvantages. It removed people from the crucial social support of family and friends, it fostered dependence, and, well, it was very expensive.
Okay, here's where it gets really interesting. During the 1950s, psychotherapeutic drugs were discovered that could relieve depression, ease anxiety, and significantly reduce psychotic behavior.
Hmm.
Once these became widely available in the 1960s, they acted as a catalyst, enabling many hospitalized patients to be discharged and treated as outpatients. This movement, known as deinstitutionalization, led to the closure or reduction in size of specialized psychiatric hospitals across Europe by the 1970s.
Right, the idea was that patients would receive care in community treatment centers, offering outpatient services, short-term hospitalization, even partial hospitalization, where individuals might get treatment during the day and go home at night.
But how well did that actually work out?
Well, the success of deinstitutionalization varied widely, offering a stark lesson in implementation. In Sweden, for example, there are now no psychiatric hospitals. Patients needing hospitalization are treated in general hospitals. However, in countries like Slovakia and Slovenia, there was little change in the use of psychiatric hospitals, and the Russian Federation actually has the highest number of inpatient psychiatric beds among the countries studied. It really highlights how complex such a sweeping policy change can be.
So the outcomes have been incredibly mixed, to say the least.
Absolutely. For some, it's been a clear success. With good economic resources, strong family support, and psychotherapeutic drugs, many have resumed fulfilling lives. One study in England found that 5 years after discharge, 90% of patients were living in the community with minimal contact with the criminal justice system. That's great.
But
But for others, deinstitutionalization has had incredibly unfortunate consequences, largely due to inadequate community services. Many individuals simply don't receive proper follow-up care, like outpatient therapy, medication monitoring, or help finding housing or jobs.
which leads to that revolving door existence you hear about.
Exactly. Cycling in and out of institutions, and shockingly, in some European cities, up to 50% of homeless people have a severe mental health problem. It's a testament to the fact that good intentions need robust support systems to actually work.
This then brings us to a crucial, often uncomfortable debate, the reinstitutionalization argument.
Yeah, it's a direct conflict between civil rights, the right to liberty, and public safety. Predicting dangerousness is notoriously difficult. While rare, highly publicized incidents of violence by individuals experiencing psychotic episodes often fuel public fear.
So what does the research actually say about risk?
What's important to note from research is that people with both serious mental health problems and a substance misuse problem are more likely to commit violent crimes than healthy people. And even those with mental health problems but no substance misuse are slightly more likely to be violent than healthy individuals without substance misuse. However, in one large study, the presence of a substance misuse problem was as strong a predictor of violence as the mental health problem itself.
So it's incredibly complex, not a simple cause and effect.
Not at all. It's a deeply complex issue with no easy answers, demanding a very careful balancing act between individual rights and community safety.
Absolutely. And with all these evolving approaches, it's worth understanding the roles within the mental health care ecosystem. We're talking about the interplay between psychiatrists who, with their MD, manage medication and hospitalizations,
Right, they can prescribe.
psychologists who typically hold a PhD and focus on psychotherapy, and psychoanalysts with their specialized Freudian training.
And what's important to remember is that these professionals often work together as a team. For instance, a psychiatrist might manage medication, while a psychologist provides individual or group psychotherapy. The key takeaway here isn't really about specific titles, but about the competence in providing care, often in a collaborative environment.
Okay, so moving beyond the history and the providers, what about the actual methods they use to help? Let's dive into the techniques of psychotherapy itself.
Sure. At its core, psychotherapy refers to a variety of psychological interventions aimed at alleviating human problems and improving overall functioning.
And while the techniques vary widely, there's a common thread. It involves a helping relationship between the client and the therapist, encouraging open discussion of intimate concerns with empathy and trust.
All to help the client develop more effective ways of handling problems. It's fundamentally about that relationship and process.
Let's start with behavior therapies. What's the main idea there?
If we look at behavior therapies, their core assumption is elegantly simple. Maladaptive behaviors are learned. Therefore, the focus is on direct behavior modification, using established learning principles to replace inappropriate responses with more adaptive ones. The goal isn't necessarily deep insight into why you do something, but rather direct, observable change that improves your daily life. Let's change the behavior first.
Right. And a classic example of this is systematic desensitization. Can you walk us through that?
Sure. First, the client learns deep relaxation techniques. Then they create an anxiety hierarchy, essentially, breaking down an overwhelming fear into manageable steps.
Like for a spider phobia, maybe just thinking about a spider is step one.
Exactly. Then,
Okay.
looking at a picture, then seeing one in a jar across the room getting closer, you build it up. Then, while deeply relaxed, the client imagines, or in vivo exposure, actually experiences these situations, starting with the least anxiety-provoking.
Until the fear subsides. And in vivo means doing it in real life.
Yes, in vivo exposure means facing the fear directly, and it's generally more effective. The brain essentially learns that the feared outcome doesn't happen, and it rewrites that fear response.
Makes sense.
Building on that, we have flooding, which is a powerful, more intensive form of in vivo exposure. This involves exposing an individual to their most feared object or situation for extended periods without any opportunity to escape.
That sounds intense.
It is intense, but it's proven particularly effective for conditions like agoraphobia and obsessive-compulsive disorders. Basically, it allows that conditioned fear response to extinguish because the feared outcome never materializes. You stay in the situation until the anxiety naturally decreases.
Okay. And on the flip side of reducing unwanted behaviors, there's selective reinforcement.
Right, which is all about strengthening desired behaviors. Imagine a 9-year-old girl who's inattentive in school. A teacher might give her a token every time she's on task, paying attention, completing assignments.
Like a reward system.
Exactly. These tokens can then be exchanged for privileges she values. This technique can also be combined with extinction, like ignoring a child who shouts for attention and only reinforcing them when they speak in a conversational tone. It's about shaping behavior through consistent feedback.
What about learning from others?
That's modeling. A client learns behaviors by observing and imitating others. For example, watching a therapist calmly handle a spider can significantly reduce the fears of someone with a spider phobia, making it possible for them to eventually do the same.
Seeing is believing, sort of.
Pretty much. And this is often combined with behavioral rehearsal or role-playing, where the therapist helps the client practice more adaptive behaviors. Take someone trying to overcome anxiety about talking to new people. The therapist might have them role-play a conversation, guiding them to use more confident, assertive phrasing, like using I statements. I feel upset when you interrupt me, rather than you always interrupt me.
Assertiveness training. That's super useful. And because therapy sessions are usually weekly, self-regulation must be key for continued progress.
Absolutely. This empowers the client to monitor their own behavior and use techniques like self-reinforcement, rewarding yourself for achieving a goal, like watching a favorite show, or even self-punishment, like maybe donating money to a cause you dislike if you fail to meet a goal.
The book gives a detailed program for eating control as an example.
Right. And behavior therapy overall has proven remarkably effective for anxiety disorders, panic, phobias, OCD depression, sexual functioning, and various childhood disorders.
Okay, so if behavior therapy focuses on direct modification, how does cognitive behavior therapy, CBT, differ?
CBT integrates the crucial role of cognitive factors,
Right.
our thoughts, expectations, and interpretations.
Yeah.
CBT aims to help clients control disturbing emotional reactions by changing maladaptive beliefs or thought patterns. The profound idea here is that how you think about something profoundly impacts how you feel and behave. It's not just the event, but your interpretation of it.
This is where it gets truly transformative. Think about treating depression. Cognitive behavior therapists help clients recognize the distortions in their thinking, like the tendency to view events from a negative, self-critical perspective. The source provides a powerful dialogue with a suicidal client who believes she's nothing without her husband, despite a miserable marriage. The therapist carefully, through questioning, leads her to realize that she was somebody before him and that her marriage isn't really a marriage at all.
Precisely. It helps the client challenge her unrealistic beliefs and test alternative views, essentially rewriting her internal narrative. It's about identifying those automatic negative thoughts and evaluating them.
And another example was treating agoraphobia, right? Combining real-world exposure with different self-talk.
Exactly. A cognitive behavioral program might combine in vivo exposure, like progressively venturing further from home with positive self-instructions. The client learns to replace self-defeating internal dialogues like, I'm so nervous I know I'll faint, with thoughts like, be calm, I'm not alone. Even if I have a panic attack, I can cope.
So the behavioral part provides mastery, which changes the thoughts.
Yes, it reinforces the idea that behavioral procedures can powerfully affect cognitive processes, leading to a profound sense of mastery. As the source states, nothing succeeds like success. When you do the thing you fear and survive, your beliefs about it change.
And the track record of CBT is impressive. It's been highly effective for a wide range of non-psychotic conditions: depression, anxiety disorders, eating disorders, substance dependence, sexual dysfunctions, even helping manage psychotic symptoms.
Definitely a powerful tool.
So if behavior therapy is about observable change and CBT adds the cognitive layer, how do other approaches dive deeper into the mind's hidden workings?
That's where psychodynamic therapies come in, originating from Freud's work. Their central assumption is that current problems stem from unconscious conflicts rooted in early relationships with parents and siblings. The goal is to bring these repressed emotions and motives into conscious awareness so they can be dealt with more rationally and their power over us diminished. It's about understanding the past to change the present.
And what are the key techniques here? I know free association is one.
Right. Free association, where the client speaks uncensored thoughts. And critically, the therapist notes resistance or hesitations as important clues to underlying conflicts. Then there's dream analysis.
The royal road to the unconscious.
Exactly. Distinguishing between the manifest content, what you literally dream, and the latent content, the hidden symbolic meaning. Another crucial element is transference.
Where the client reacts to the therapist like there's someone from their past.
Precisely. Reacting as if the therapists were significant figures from their past, like a parent. The source gives an example of a client wanting the therapist's approval, which the therapist points out might reflect conflicts with the client's wife. This helps the client understand their own patterns.
But traditional psychoanalysis is, like, years long, right? Very intensive.
It is. Lengthy, intensive, expensive, and often not suitable for acute symptoms. However, contemporary psychodynamic therapies like interpersonal therapy, IPT, are much briefer and more structured. They focus more on the client's current interactions and relationships, with direct discussion of critical issues and less emphasis on a complete reconstruction of childhood. And research shows these contemporary approaches are effective for depression, anxiety, addiction, and eating disorders.
Okay, then we have humanistic therapies, like Carl Rogers' client-centered therapy. What's the philosophy there?
This approach emphasizes an individual's natural tendency toward growth and self-actualization. The belief here is that psychological disorders arise when this potential is blocked, perhaps by negative self-concept or external pressures, leading people to deny their true desires.
So the goal is self-discovery, finding your true self.
Essentially, yes, and making deliberate choices to live a more fulfilling, authentic life. Unlike psychodynamic approaches, humanistic therapies focus squarely on the here and now.
And in client-centered therapy, the therapist isn't directive.
Not at all. The client is considered the expert on themselves, and the therapist acts as a facilitator or a mirror, offering empathy, warmth, and genuineness, what Rogers called unconditional positive regard, without interpreting or imposing views. The therapist strives to see problems from the client's frame of reference, accepting them as they are, which creates a profoundly safe space for self-exploration and growth.
It sounds powerful, but maybe not for everyone. The book mentions limitations.
Right. It tends to be best for verbal and motivated clients. It's often less effective for seriously disturbed individuals who might need more structure or intervention, and it may sometimes overlook the immediate need for concrete behavioral changes in the real world.
Gotcha. Now, what about looking beyond the individual, sociocultural approaches?
This is where sociocultural approaches offer another essential perspective, viewing individuals within larger social systems, families, communities, and culture, and addressing these systems in therapy. It's about recognizing that we don't exist in a vacuum. Our context matters deeply.
Group therapy is a great example of this, right?
Absolutely. It provides a dynamic setting for exploring relationships, observing how others react, and trying out new responses in a social context. It's efficient, offers comfort from shared problems, I'm not alone in this, allows for vicarious learning by seeing others cope, and provides a safe space to practice new social skills.
And self-help groups like AA fit here too.
Yes, groups like Alcoholics Anonymous are voluntary organizations, usually without a professional therapist leading them. where people meet to support each other in overcoming common problems. The peer support is key.
And within this sociocultural umbrella, you also have marital and family therapy.
Right, specialized forms of group therapy. Marital therapy focuses on improving couples' communication and conflict resolution. Studies consistently show it's more effective than individual therapy for marital problems specifically.
Makes sense, you need both people there.
Exactly. And family therapy treats the entire family system, recognizing that an individual's problems, especially a child's, are often symptoms of a broader family dysfunction or communication pattern. It can be vital in cases involving children's behavioral issues, or even for improving communication within families dealing with schizophrenia, reducing relapse rates.
Speaking of children, the book mentions special issues in treating them.
Yes, it really highlights the sociocultural aspect. Therapy must match the child's developmental level. You can't do talk therapy with a toddler the same way you would with an adult. Often the entire family needs treatment, as the child's struggles are often intertwined with family dynamics.
Plus, kids rarely refer themselves for therapy.
That's a big one. It impacts motivation sometimes. And sadly, many children who could benefit from therapy don't receive it, highlighting a significant need for expanded services tailored to their unique needs and involving their families and schools.
Okay, so we've covered a lot of different approaches. Now let's talk about the big question everyone asks. How effective is psychotherapy? Does it actually work?
Evaluating outcomes is more challenging than you might think, for a few reasons. For one, there's spontaneous remission, the fact that 30 to 60% of people improve without professional treatment, often due to external events changing or help from friends, family, clergy, etc.
So you need control groups in studies.
Exactly. Studies need to compare treated groups to control groups, perhaps people on a waiting list, to truly isolate the therapy's specific impact beyond just the passage of time or other factors.
And defining success itself is tricky, right? Who decides if it worked?
That's the other challenge. We can't always rely solely on the client's report. They might want to please the therapist or justify the expense. The therapist might be biased too. Objective measurement ideally requires at least 3 independent assessments: the client's view, the therapist's view, and the judgment of a third party, like family members or an uninvolved clinician looking at specific behaviors or symptoms.
Okay, so despite those challenges, what does the evidence say?
The evidence is actually pretty strong. Meta-analyses, which combine results from many studies, consistently confirm that psychotherapy does have profound positive effects. The average patient who receives therapy shows greater improvement than 80% of comparable untreated individuals.
Wow, 80%. That's a powerful statistic that truly validates its impact.
It really is. Therapy works.
What about comparing different therapies? Is CBT better than psychodynamic, for example?
That's another fascinating question. The general conclusion from many reviews, often called the dodo bird verdict, everybody has won and all must have prizes, is that there's surprisingly little difference in overall effectiveness between major therapeutic approaches when averaged across all disorders.
Really, that seems counterintuitive.
It does, but there are a couple of potential reasons. One is that specific therapies are likely best for specific problems. For example, CBT and behavior therapy are generally considered the treatments of choice for anxiety disorders and depression. So matching the therapy to the problem matters. But more profoundly, it suggests that many therapies, despite their different theories and techniques, share common factors that drive positive change. These underlying elements might be more important than the specific school of thought.
The secret sauce of therapy. What are these common factors?
Well, first, and maybe most critically, a strong, warm, and trustful interpersonal relationship between the client and therapist. That alliance is paramount.
Okay, the relationship matters. What else?
Second, reassurance and support. Therapy provides a safe space, and the therapist's support instills a sense of hope, which is absolutely vital for recovery. Just believing you can get better is powerful.
Hope.
Third, desensitization. Talking about problems, exploring fears in a safe setting, or through repeated, structured exposure like we discussed in behavior therapy, helps them lose their threat.
Makes sense. Less scary over time.
Fourth, reinforcement of adaptive responses, whether it's explicit praise for progress or subtle cues like a nod or an encouraging, therapists reinforce positive changes.
And
Finally, understanding or insight. Therapy provides a plausible explanation for the client's difficulties and a belief in the therapeutic activities designed to alleviate distress. Having a framework, A story that makes sense of the suffering is incredibly helpful.
So it's these core elements, relationship, hope, desensitization, reinforcement, and insight that might be the universal ingredients for effective therapy, regardless of the specific brand name.
That's a leading theory, yes. These common factors seem to cut across different approaches.
Okay, let's shift gears now to biological therapies. What's the underlying philosophy here?
The biological approach views mental health problems primarily as biochemical or physiological dysfunctions of the brain. So the treatments aim to correct these biological issues. The two main types we'll explore are drugs and electroconvulsive therapy.
Right. Psychotherapeutic drugs, introduced back in the early 1950s, have had a truly revolutionary impact. They've reduced the need for physical restraints in hospitals and allowed for quicker discharges. Let's talk about the different types, antipsychotics.
Antipsychotic drugs, like the older chlorpromazine or newer atypical ones like clozapine and risperidone, primarily work by blocking dopamine receptors in the brain. They're highly effective for the positive symptoms of schizophrenia, like hallucinations and confused thinking, though they don't cure the illness.
But they come with side effects, right? I remember reading about tardive dyskinesia.
Yes, that's a major concern with the older antipsychotics. Tardive dyskinesia involves involuntary, repetitive movements, sometimes facial tics like lip smacking or grimacing, and unfortunately, it can become irreversible in over 20% of long-term users. The newer atypical drugs generally have a lower risk of this specific side effect, but they have their own potential issues like weight gain or metabolic changes.
Okay. What about antidepressants?
Antidepressant drugs work by regulating neurotransmitters involved in mood, primarily norepinephrine and serotonin. You have older types like MAO inhibitors and tricyclics, and the newer, more commonly prescribed SSRIs, selective serotonin reuptake inhibitors like Prozac or Zoloft, and SNRIs, serotonin norepinephrine reuptake inhibitors.
And they just make more serotonin available, basically.
SSRIs specifically block the reabsorption or reuptake of serotonin, leaving more of it active in the synapse. While they all can have side effects like dry mouth or sexual dysfunction, the newer SSRIs and SNRIs generally have improved side effect profiles compared to the older drugs, making them more tolerable for many people.
Then there's lithium for bipolar disorder.
Right. Lithium is a mood stabilizer, often effective in controlling the dramatic mood swings of bipolar disorder. It seems to work by stabilizing various neurotransmitter systems. However, it only works well for about 30–50% of patients. The therapeutic dose is close to a toxic dose, requiring careful monitoring, and side effects can be significant. Anticonvulsant drugs are also now commonly used, especially for acute mania or as alternatives to lithium.
And anti-anxiety drugs, like Valium.
Yes, drugs like diazepam, Valium, belong to the benzodiazepine class. They are tranquilizers that depress the central nervous system, effectively reducing tension and anxiety. They work quickly, but can be addictive and cause drowsiness. Interestingly, some antidepressants, particularly SSRIs, are also very effective for treating anxiety disorders long-term.
Lastly, stimulants for ADHD. Seems paradoxical.
It does. Stimulants like methylphenidate, Ritalin, are used for ADHD. They actually increase the activity of dopamine and norepinephrine in brain areas related to attention and impulse control. This helps reduce disruptive behavior and increase focus in children and adults with ADHD.
So drugs have been hugely beneficial, but what are the downsides?
Well, as we've touched on, all psychotherapeutic drugs can produce undesirable side effects. They might not be suitable for everyone, like people with certain medical conditions or during pregnancy. And a broader concern, especially among psychologists, is that these drugs often alleviate symptoms without necessarily addressing the underlying personal problems, coping skills deficits, or environmental stressors that contribute to the disorder.
It's treating the symptom, not always the cause.
In many cases, yes. It's a powerful tool, but often not a complete solution on its own, which is why therapy is often recommended alongside medication.
Okay, what about the other main biological treatment mentioned? Electroconvulsive therapy, ECT. It has a pretty controversial history.
It certainly does. ECT involves applying a mild electric current to the brain to induce a brief seizure. It was actually quite popular from the 1940s to the 60s, but faced immense controversy due to reports of indiscriminate use, patients finding it frightening, significant memory loss, and even physical injuries like bone fractures when it wasn't properly administered with muscle relaxants.
But modern ECT is different.
Oh, vastly different. Today, patients receive short-acting anesthesia and muscle relaxants, so they feel nothing, and their body doesn't convulse violently. A brief, weak electric current is typically applied to the non-dominant hemisphere of the brain to minimize effects on verbal memory. The patient wakes up quickly with no memory of the treatment itself. While the exact mechanism is still debated, we know seizures cause a massive release of neurotransmitters like norepinephrine and serotonin. ECT is remarkably effective, and often very rapid, for severe immobilizing depression, especially when patients haven't responded to medication or are acutely suicidal.
Faster than drugs.
Yes, often much faster. It can be life-saving in crisis situations, providing relief within days or weeks, whereas antidepressants can take several weeks to reach full effect.
This leads us neatly to the modern trend, combining biological and psychological therapies. Why is this becoming so common?
It just makes so much sense, especially for disorders that clearly affect not just brain biochemistry, but also a person's thoughts, feelings, social functioning, and work life. Why treat just one part when the whole person is impacted?
It's tackling the problem from multiple angles.
Exactly. The fundamental idea is that intervening at one level of a person's biopsychosocial system, say, using medication to adjust brain chemistry, can profoundly affect the other levels, like improving mood enough for someone to engage in therapy. And conversely, therapy can help people develop coping skills that might reduce biological stress responses. They're intertwined.
It's a truly holistic approach to healing, recognizing the complex nature of mental health.
Precise.
Now, let's talk about the truly cutting edge, innovative neurostimulation treatments. These sound fascinating ways to stimulate the brain without the seizure of ECT.
That's the idea. Building on ECT's success, but aiming for fewer side effects and more targeted approaches. One incredibly promising method is repetitive transcranial magnetic stimulation, or rTMS.
Magnetic stimulation, how does that work?
It uses strong, focused magnetic pulses delivered by handheld coils placed over specific parts of the scalp. For depression, it often targets the left prefrontal cortex, an area often underactive in depressed individuals. These pulses painlessly pass through the skull and induce electrical currents that stimulate the neurons below.
And the effect?
It seems to increase neuronal activity in that targeted region. Studies show it can significantly relieve depressive symptoms, especially for patients who haven't responded well to drug therapies. The side effects are generally mild, maybe a minor headache, and importantly, the patient remains awake and alert during the short procedure. No anesthesia needed.
That sounds like a big advantage over ECT for some people.
Oh.
What about vagus nerve stimulation, VNS? That involves an implant.
Yes, VNS involves a small electronic device, much like a cardiac pacemaker, that's surgically implanted under the skin in the chest area. A wire runs under the skin, connecting the device to the vagus nerve in the neck.
And stimulating that nerve helps with depression.
It seems to. The vagus nerve is a major communication pathway between the body and the brain, carrying information to areas involved in mood regulation. VNS sends regular mild electrical pulses up the nerve, and this seems to induce changes in brain blood flow and neurotransmitter activity similar to antidepressants.
Where did this idea come from?
Kind of serendipitously. It was first used to treat epilepsy, but clinicians noticed that many of their epileptic patients also experienced significant improvements in their mood. So researchers started studying it specifically for treatment-resistant depression.
And is it effective?
It shows promise. Studies suggest it leads to significant improvement in about 30% of patients with major depression who haven't responded to multiple other treatments. That's notably better than the typical 10–15% response rate seen when just trying another drug in that population. Side effects can include temporary voice alteration or hoarseness and coughing during stimulation, but it offers another avenue for very difficult-to-treat cases.
Really interesting developments. Okay, switching gears completely now, beyond professional therapies, let's talk about proactive steps you, the listener, can take to enhance your own psychological well-being. What can we do on a daily basis?
That's a great question. One of the first and most important things is simply to accept your feelings. Unpleasant emotions like anger, sorrow, or fear are normal parts of the human experience. Recognizing them rather than denying or suppressing them is key. If direct expression isn't possible or appropriate, find healthy outlets, maybe vigorous exercise, journaling, or talking it through with a trusted friend.
Okay, accept feelings. What else?
Second, know your vulnerabilities. Try to identify situations, events, or even types of people that reliably upset you or trigger negative reactions. Understanding why they affect you is the next step. Then you can develop specific strategies to cope. Maybe that involves learning a new skill like public speaking if that's a trigger, or consciously working to reinterpret negative thoughts related to those situations.
So self-awareness leading to a plan. I like that.
Exactly. Third, develop your talents and interests. Engaging in activities you enjoy and are good at is a powerful way to combat boredom and feelings of uselessness. It increases your sense of competence and naturally boosts self-esteem. Find something that absorbs you.
Makes sense. Get involved in things. And people.
Critically important, become involved with other people. Feelings of isolation and loneliness are really toxic to emotional health. We are social creatures. We need the support, companionship, and reassurance of others. Sharing concerns helps, and interestingly, focusing on others' welfare and helping them can profoundly reinforce your own sense of self-worth.
It's a fundamental human need to connect.
Absolutely. And finally, know when to seek help. There are limits to self-understanding and self-help. If you feel like you're stuck, not making headway on your own, or your struggles are significantly impacting your daily life, relationships, or work, seeking professional help is a sign of emotional maturity, not weakness.
Don't wait until things are completely overwhelming.
Please don't. Early intervention is always better.
Great practical advice. Now, for our Seeing Both Sides segment, we're tackling a highly debated topic. Is Alcoholics Anonymous, or AA, an effective intervention for alcohol misuse? It's so widely known, almost iconic, but is it the only path, or even the best path, for everyone?
It's a really important question. From the pro-AA perspective, presented by Keith Humphreys in the text, AA is framed as a massive worldwide fellowship, about 2 million members, promoting complete abstinence from alcohol through mutual help and the spiritual framework of the 12 steps.
And it's incredibly common in the U.S.
Hugely common. It's the most frequently sought source of help for alcohol problems, far outstripping professional interventions. Research, including the large-scale Project Match study, suggests that AA involvement does increase long-term abstinence rates, and that professional counseling designed to facilitate AA involvement is as effective as other established psychotherapies like CBT.
What about cost?
That's a major point in its favor. Because AA attendance is free, it's incredibly cost-effective. Humphreys argues it potentially takes a substantial burden off the formal healthcare system. One study even found AA attendees had 45% lower alcohol-related healthcare costs over 2 years compared to those receiving formal outpatient treatment.
Okay, so a strong case for its effectiveness and accessibility for many. But what about those who don't connect with that specific AA model?
That's where the alternative perspective, argued by G. Allen Marlett, comes in. He points out potential barriers. For instance, retention rates can be low. Maybe only half the people who go to one meeting return for a second. Some individuals are uncomfortable with the core tenets like admitting powerlessness over alcohol or the emphasis on relying on a higher power, whatever that means to the individual.
And the disease model requiring total abstinence forever.
That can be a barrier too. It might not resonate with everyone, especially those whose problems aren't yet at a severe stage. Marlett suggests that the effective component might be the general group support and sense of community, rather than AA's specific teachings. He highlights alternative self-help groups.
Like what?
Groups like Rational Recovery, which is based on rational principles and doesn't involve a higher power, Smart Recovery, self-management and recovery training, which uses cognitive behavioral principles, and Women for Sobriety, which offers an approach tailored specifically for women. These provide options for people seeking mutual help outside the AA framework.
And then there's the whole idea of not insisting on total abstinence harm reduction.
It's exactly. Marlett champions moderation management and the broader harm reduction approach. The goal here isn't necessarily immediate and total abstinence for everyone, but rather reducing the negative consequences associated with substance use. This could involve accepting smaller steps toward less harmful use, even if it's not zero use. For example, teaching safer drinking strategies to high-risk college students. Studies he mentioned showed such programs significantly reduced binge drinking episodes and alcohol-related negative consequences like blackouts.
So it offers strategies before someone hits bottom.
That's a key critique Marlett makes of the traditional AA hit bottom doctrine. Harm reduction aims to provide helpful interventions and strategies for people who are experiencing problems but may not be ready or willing to commit to lifelong abstinence, or who haven't yet reached a crisis point. It's about meeting people where they are and helping them make positive changes, whatever those might look like initially.
A really nuanced debate with strong points on both sides. It highlights that recovery pathways are very individual.
Absolutely. What works for one person might not work for another. Having options is crucial.
This deep dive has truly laid bare the profound transformation in our understanding and treatment of mental health. From the ancient, often brutal beliefs in evil spirits and exorcism, through the dark ages of asylums, to Panel's revolutionary humane care, and finally to today's diverse, scientifically informed, and often highly effective approaches, It's been a journey of immense progress, though clearly still with challenges.
It really has. And as we consider this constantly evolving understanding of the brain and behavior, it leaves us with a provocative thought. Given the rapid pace of technological innovation, things like AI, brain imaging, genetic insights, how might technology and personalized medicine further revolutionize mental health treatment in the next few decades? And perhaps just as importantly, what ethical considerations must we keep firmly in mind as we push these powerful new boundaries?